So without further ado, I'd like to introduce our first speaker, Professor Kjell Oberg. Many of you will know Kjell from his publications, but he's been an instrumental key opinion leader and one of the key leaders of the movement of research and clinical practice in neuroendocrine tumor management internationally. And it's been always a great pleasure having him here. I'd like to welcome him to the podium. Thanks.
Thank you very much, Nick, for this kind of introduction. And good morning, everybody. And it has been a long trip to get here, but I'm standing up. And what I will do this morning is actually to review some of the issues we are discussing in Europe, and also taking something from NETS, the last NETS meeting in US. So what I will discuss is biomarkers, because we had to develop new biomarkers. And we have also to discuss molecular imaging a little bit, but that is also in the next session, so maybe I will rush over that. And then we have immunotherapy, which is coming very broadly now, at least in Europe. So if we look at diagnostic advances in neuroendocrine tumors over the years, and I have been actually part of many of these developments, because I started already in 1974 to work with neuroendocrine tumors, so 41 years in the field now. And if I look at the new developments in the field that is now discussed, at least in Europe, and also I recognize that NETS, is the microRNAs, multiple transcript analysis in blood, circulating tumor cells, and of course next generation sequencing, which we will hear more in a later session. So if we start with microRNAs, this is a family of small non-coding, highly conserved single-stranded RNAs, and they have been evaluated in different trials. There were a lot of different posters at the last ENETS. And one of the first presentations, and also giving some hint that this might work in the clinical practice, is this first trial published already in 2014 with microRNA 21 in pancreatic NETs. And as you can see, the difference between normal islets and pancreatic neuroendocrine tumors. And this has not been pursued further in clinical trials, so we don't see the value of it just now, but I think that is something that will come later on. We have been studying a lot of microRNAs in small intestinal NETs, and we saw an expression of 5 microRNAs that were significantly upregulated in small intestinal NETs. And the interesting thing that we have also downregulated microRNAs. So there is a problem. How should we interpret this data? One interesting finding is that if you look, these are healthy donors. And if you look at primary tumor, lymph node metastasis, and liver metastasis, with the spread of the disease, you get higher and higher levels of microRNAs. And that was typical for all these tested. And if you look at 196 microRNA, it's involved in regulation of transcription, DNA-dependent, Wnt signaling, and Wnt receptor signaling pathways. So I think it's very important to start to know more about these microRNAs that we have in the circulation at the moment. And I think that must come in the future. Liquid biopsy. If you look at this, that has been discussed over several years now, but just come into clinical practice. And the first test that I really want to discuss with you that take this into consideration is the NET test. And I know that for many of you, you have been thinking that this might not be something that is working, that, and it has been maybe sell as a solution of all problems. But I can just bring it up now because I personally experienced from around 75, 80 patients that we have followed with it, and it seems to work actually. So we can use liquid biopsy for early detection, screening, new targets, monitoring of treatment, personalized therapeutics to develop new therapeutic agents, and to look at the targeting therapies. So what we are analyzing in liquid biopsies is actually proteins, hormones, circulating DNA, RNA, and also microRNA, as I said. So we have circulating tumor cells, we have oncosomes, we have tumor exosomes, and we have, of course, circulating nucleic acids. So there is a lot of substances circulating in the blood that we can use for analyzing our patients. And that has not been so much developed in neuroendocrine tumor as in other malignancies. So whole blood captures the tumor signature. So therefore, I want to discuss with you the ENETS test, and it has been around since 2010 and has been more than 22 publications just now. And this is a specific net-specific transcriptome analysis that is developed by Professor Modlin and Mark Kidd in US. And it's only taking into consideration neuroendocrine tumor transcriptomes, so it's not seeing other malignancies. So if you have an adenocarcinoma, you will not pick up this with this tumor signature. And it takes a messenger RNA from tumor tissue, from tumor blood, and of course, then they had made this ENETS test, 51 mRNAs that capture the ENETS signature. And if we look at so far, which has been published, it has a sensitivity above 90%, specificity of 90%, positive predictive value 90%, negative predictive value 90%, and area on the rock curve more than 90%. So the accuracy is more than 93%. So I mean, this has been doubted because there have been no randomized controlled trials. But there are such trials now ongoing in Europe. We have the sector trial driven by ENETS. So I think there will be data coming out. But I think it's time to consider this test as something that we can use in the clinic in the future. So if we look at this gene expression, 51 markers, and it has been looking at growth factor and signaling, secretion, somatostatin receptor expression, epigenetic regulation, metabolism, apoptosis, and proliferation. So it captures different areas of tumor development, and so therefore I think it can be even more improved in the future, but we have to stick with it at the moment. And one of the shortcomings that I have been discussing with Professor Modlin is that we can't get just a single information, let's say proliferation or metabolism or apoptosis. We get the whole concept with this 51 gene construct. So because of lack of time, I will go through it quite quickly, but you can get results from taking a blood test within 8 hours. And what is happening now is they are establishing a laboratory in Europe, so it can be introduced into the clinic. So now they have 2 laboratories, one in US and one in Europe. And the NET test comes out with information that you have a high risk of tumor proliferation, more than 80%, intermediate 41 to 79%, and low less than 40%. And these are the early publications coming out where they compare with chromogranin A. Unfortunately for me, I was the guy that introduced chromogranin A worldwide. But now we are trying to kill it. So, but it performs better than chromogranin A, I can tell you. So the NET test has a sensitivity of 85 to 98% in different studies, and specificity up to 97%. And these are different publications coming out, and this is also a study looking in well-differentiated paragangliomas and pheochromocytomas. So it's not only small intestinal or pancreatic NETs, it's also cover other neuroendocrine tumors. And as you can see, it performs quite well also in these diseases. So we can now differentiate between stable and progressive disease using this test. After surgery, and particularly if you're trying a R0 resection, you want to know if you can rely on that or if you have still remaining disease. And this is done in several centers now, looking at, and if you have an R0 resection, you can see that the NET test become normal. But if you have residual disease, it's still elevated. And so it correlates with the tumor removal. And here are different centers participating in looking at the NET test after surgery. And if you can see both from London, from Milan and Turin, you can see that if you have a R0 resection, you had a drop in the NET test indicating that you have done a good job as a surgeon. If you have residual disease, the NET test is still elevated. If you look at the response to somatostatin analog therapies, that has been done in several trials now. And what is interesting is that the NET test predict failure to somatostatin analog treatment several months before you can see any changes in radiology. And that is, of course, very important if you want to change the treatment for the patient. You can also monitor response to PRRT. This is a multi-center trial done with a group in Rotterdam, Lisa Baudet in Milan, and also the group in Basel. And they could demonstrate that if you have a good effect of your PRRT, you can see that the NET test become normal within 6 months after starting the PRRT. If you have a less effect, the NET test is still elevated. That could not be demonstrated with chromogranin A, unfortunately. So there it also shows a value in the clinical practice in the future, because if you can, at an early stage, indicate if the patient has any value of PRRT, you can save a lot of money. So if we look at summarized this test, the NET test, it has a high sensitivity and specificity. It's a robust technology. It can confirm complete resection and also identify minimal residual disease post-surgery. I recall a patient that was done surgery in a lung net, and they were asking if there might be any residual disease, and nothing could be seen, but this net test indicated that there must be residual disease. I saw it personally, this test, because it was from my own clinic. And after another 3 to 4 months, we could see a small lesion that was also now picked up on gallium PET scan. So it can monitor the treatment efficacy and also identify the risk of treatment failure and disease progression. And I think it's an important tool to work together with the extremely good imaging techniques we have now, molecular imaging techniques. Circulating tumor cells, briefly, very few trials, very few studies. And the reason is that there are very few circulating tumor cells. It's not like in colorectal or other. You count them as single circulating tumor cells. So it's a tricky. But this is a study from London, and that was followed up and at the last ENETS. But no significant new data came out of it. But if you have less than one circulating, it means 0 circulating tumor cells, you had a significantly better PFS and overall survival. So that is the essentials of this trial. So I don't think that this will be something that will be pursued in so many centers, at least not in Europe at the moment. Molecular genetics, I just briefly mentioned that this came out from a study in US looking at molecular profiling of neuroendocrine tumors and what we know from previous data. And I think that will be alluded by you later this morning. But this study was also brought up at NANETS, and what you can see is that if you have neuroendocrine cancers, you see more mutations. But if you look at non-pancreatic NETs, you have very few mutations. And all in small intestinal NETs, you hardly see any mutations at all. So, as you can see from this study, almost 80% had no mutation at all in non-cancerous patients. So. But this is something we had to live with because the patients are coming to you with molecular profiling. There are a lot of commercial centers now that offer this possibility. So this is one of my personal patients coming from Switzerland, and he had this molecular profiling, and he had these alterations in the MET amplifications, CCND1 amplification, MDM4 amplification in his tumor. And so he wanted to have cabozantinib as treatment, and I told him that this is not the standard we are offering for pulmonary NET. So, but he wanted really to pursue what he has seen in molecular profiling. Unfortunately, it didn't work. So we have still to learn more about how to use this molecular profiling. And this is the important paper from Aldo Scarpa that was presented in Science, and then it was presented at ENETS and discussed. And I think this is, a very important paper indicating new targets for treatment of pancreatic NETs. So, and as you can see here, multiple endocrine neoplasia, the MEN1 gene is involved in a lot of pancreatic sporadic pancreatic NETs. And you have changes in DNA damage repair, CHEK2 and MUT-H, and BRCA2 was also very surprising. And then you have changes in chromatin modification, altered telomere length, and you have, of course, which has been well evaluated with the mTOR inhibitors, mTOR signaling. So I think this opens new avenues for treatment in patients with pancreatic NETs. Molecular imaging, I will go through it very rapidly. The only thing I want to mention now, which is ongoing in Europe, is alpha particles, not beta irradiation, but alpha particle, and terbium-149 and terbium-155 is now explored, particularly by Professor Richard Baum in Bad Berka. And this is some of the early studies indicating that you have the same distribution of this alpha particle compound as with the lutetium DOTA-NOC. And you can also see that these are the first human imaging using terbium-152 and also with predictive dosimetry. So alpha emitters is coming now, at least in some centers in Europe. If you look at therapeutic advances in NETs, we have some new data coming out here on telostrat ethyl, which I am not going to discuss. PRRT, we will hear from Dr. Strasberg about NET-1. So I will not discuss that either, but I will go for cancer immunotherapy because that is something that has just started, and I will skip a lot of slides because I'm short of time. But you know that we have antibodies against this immune block, PD-1, PD-L1, and there is a lot of different malignancies that have been tested for these antibodies, and also PD-L1 antibodies, not only PD-1. And I'm particularly interested in Merkel cell carcinoma because that is a neuroendocrine tumor. The problem with neuroendocrine tumors is here, and I think that is something you had to realize, that you have we call it immune desert. You have no infiltrating lymphocytes, CD8 or CD4. So therefore you had to try to get CD8 T cells infiltrating in the tumor. And how can you get that? You can get it by giving oncolytic viruses at the same time. So we have to convert this silent tumor into an inflamed phenotype, which is this type with infiltrating CD8 lymphocytes. So that is the problem with at the moment with the immune therapy in neuroendocrine tumors. So immunogenic cell death convert these cold tumors into hot tumors, and that is something we try now with oncolytic virus to convert them into hot tumors from being cold ones. And so the mode of action of oncolytic virus immunotherapy is to get the virus into the tumor cells, start to proliferate in the tumor cells, releasing a lot of new substances coming out, stimulating dendritic cells to produce new T cells, and then this attack on the cancer cells. And The oncolytic viruses in clinical trials today are a lot of them. I'm just going to discuss adenovirus, which we have been using, but also some other virus. Okay. If you look at the first registered oncolytic virus is the T-VEC, which is an herpes simplex virus. And this virus is engineered to secrete GM-CSF. And it has been used in phase 1 and phase 3 trials in combination with anti-PD-1 and CTLA-4 antibodies, so these immune block antibodies. And this is a study recently published. And as you can see that if you combine this T-VEC oncolytic virus with pembrolizumab, PD-1 antibody, you had a significant prolonged progression-free survival and overall survival in this study. It was not a randomized controlled study, which has to be, of course, performed. So if we look at immunotherapy for neuroendocrine tumors and cancers, and using both the immune block antibodies and oncolytic viruses, there is a lot of trials ongoing. And one of the trials is, of course, our trial, but also this interesting trial from Australia in Olivia Newton-John Cancer Research Institute, with combination of PD-1 and CTLA-4 antibody in rare tumors, including neuroendocrine tumors. I don't know if any one of you are involved in this trial, but you are.
We've got a number of rare tumour.
Okay. Good.
And I've had one lung net patient. It's amazing.
Okay. Good. So Merkel cell carcinoma, as I mentioned, is a neuroendocrine tumor, and of course that has been looked at because of the etiology with the cell polyoma virus that is said in 80% of the patients to be involved in Merkel cell tumor development. And this is a multicenter phase 2 study, 88 patients. And if you look at the results giving a PD-L1 antibody, you had 8 complete remission, 20 partial remission. So it seems to work quite well in Merkel cell tumors. And these are the results in different single patients. So now it's approved by FDA for treatment of Merkel cell by FDA. This is another study in 25 patients with pembrolizumab and PD-1 antibody. And they had objective responses seen in 56% of the patients by RECIST criteria, and 4 complete and 10 partial remissions. And again, you can see in single patients that you have some complete and partial remissions with immunotherapy. This is an interesting small study in 2 patients giving an oncolytic virus encoding GM-CSF together with an anti-PD-1 antibody and direct injections into the tumor, and you can see that is complete disappearance of the tumor. And that is also seen here on the CT scan. You have a tumor here, and after direct injection, it's completely gone. So we have been working with adenovirus. It's an early phase 1, and we have changed the virus by introduction of the new promoter, the chromogranin A promoter. And we have also modified in other ways the virus, giving a microRNA. And just briefly also changed the fiber knobs, introducing a motif of a somatostatin receptor. So, And these are the first animal experiments, injection of bone cells into nude mice, almost complete clearance on day 32 by this new oncolytic virus, and also the survival of the mice compared to those only got PBS. So what is now ongoing with this study is we give it to different types of neuroendocrine tumors. They should present with liver-dominant disease because we infuse it into the hepatic artery, and it's giving a third-line treatment. And these are some of the early data. This is the first patient. We had a 64 millimeter tumor, and it reduced down to 55 millimeter after the first injection of this oncolytic virus. Now we have only included 10 patients, so we want to have at least 12 patients in the first phase 1 until we make a clear evaluation of the results. But the next step in our view is to combine it with immune block antibodies. And that is already shown in this, where PD-1 antibodies plus oncolytic virus showing a significant better anti-tumor efficacy compared to the single agent treatment. So the next step for us is to, in the phase 2, to combine the oncolytic virus with PD-1 antibodies. So the conclusion, immunotherapy might be a new promising treatment for neuroendocrine tumors. Trials are ongoing. You have been part of the Novartis trial, many of you, and it can be combined, immunotherapy, with other therapies. It can be combined with chemotherapy, with PRRT. I think this is a very interesting combination to use it together with PRRT, because you introduced an immune response in the liver when you treat the patients with PRRT. So I think that is something we had to look to in the future. So by that, I'm far above my allotted time, but thank you for your attention.
The molecular profiling, do you think there's a chance that it will assist in deciding who are the patients that are most suitable for targeted therapies like sunitinib and everolimus, or will we continue to use them when we can?
I don't think molecular profiling is helping us very much there. I think we had to use them as we had done before. I think how we use the molecular profiling now in our clinic is that if you are coming to third line or fourth line treatment and you don't know what to do, then we do molecular profiling and maybe come up with some new mutations. I had recently a patient with a BRAF mutation. I didn't expect to see a BRAF mutation in the pancreatic net. But this patient got a combination of a MEK inhibitor and also a BRAF. Okay. So what I said was I had a patient with a BRAF mutation and he had received 3 other therapies before, and I didn't know what to give him at this moment. So we did this molecular profiling. He had a BRAF mutation, V600, and we get a combination of a BRAF inhibitor as well as a MEK inhibitor, and he completely responded. He was totally tumor-free after 6 months. So we had to learn more about it. But I also showed you the case where it didn't help at all.
Any other questions? Or if not, we'll move on. Kjell, I'd like to thank you for travelling 48 hours to spend about 48 hours with us. That was an amazing snapshot.